is from 10 till 11. We've got around 15 minutes dedicated to questions at the end of that time. If you are asking a question when we get to the Q&A at the end, if you please pop your hand up, or if you feel more comfortable to, pop something in the chat, and we'll try to ensure that any questions in there are addressed too. The slides will be emailed out along with a recording and an evaluation form, which is really helpful to us in the centre to help us collate some feedback as we develop the office. So we'd be really grateful if you could take just 30 seconds to fill that in. It is a very short form. During the webinar, you can access closed captions by clicking More on your Teams toolbar, then Language and Speech, then CC Live Captions. I'll also put that into the chat. So on to our speaker. Dr. Susan Hampshaw is the Director of HDRC Doncaster and Chair of Newcastle's Specialist Centre for Public Health Advisory Board. Susan's career spans local authority, academia and the NHS, and she's been with the City of Doncaster Council for the last 13 years, leading on tackling health inequalities and helping to develop the use of evidence to build a stronger connection between what is known and what actions are taken. So Susan, I'll let you take it away.
Thank you very much, Nicola. So hello, everybody. It's a great pleasure to be here today, and I really appreciate the opportunity to talk about something that I found professionally interesting for well over 20 years. And it's great that so many people are also interested. And ideally, what I'm going to try and do today is talk about some of my learning, but I'm going to really tell a bit of a story about this gap, the gap between what we know and what we actually do. And when I say know, I mean what we know derived from research and how we actually can try and get that into practice. So I've learned lots over the years, the scarily long number of years. I'm going to do a little bit of a story around some of the basis of how we started thinking about getting evidence into practice and policy. I'm going to talk a bit about the local government context and the need for us to think about how we can weave evidence to inform policy and decision making. I'm going to draw on some research studies that I've been involved with, and I'm going to give some examples of what we've done within HDRC Doncaster and our ongoing learning in this area. We have a real value around trying to learn by doing. And I'm going to try and consider some of the things that we might all want to work on around creating evidence more enriched settings so that evidence feels like the default and people can access easily and think about how to weave it in. As a bit of an alert, I will use numerous metaphors and analogies and stories in the conversation, and a kind of sorry not sorry. And one of the reasons that I'm going to do that is that over the years, I found that one of the best ways of trying to bridge the gap between what we know and what we do is to actually work out how you can weave the evidence into a story using different techniques to try and really appeal to people in a way that they can see the evidence being valuable. And I think that that's particularly the case in local government, the importance of stories and not just numbers. So that's kind of what I'm going to attempt to do today. So I'm going to start off with a little bit of a history lesson, and some of this is where I came in. I started work after I graduated scarily in 1991 in a medical audit team in a really busy, large teaching hospital. And we were interested in looking at the variation in clinical practice between different teams. And we wanted to set some standards and audit against those standards. And that team that I joined back in 1991 was led by a really inspiring public health consultant to whom I owe my entire career, and also my passion for both getting evidence into practice, this sort of bridging the gap stuff, which it's woven through my entire career, but also my passion for capacity building, because I think he really, and by that I mean building the skills of individuals to work in this area, because he spotted something in me, he funded my master's, and the rest is kind of history. But moving away from the sort of autobiography, as a team working in a large teaching hospital in Leeds, we were really interested in some of the ideas coming from the evidence-based medicine movement, and in particular Dave Sackett, who was at although from the US, was in Oxford at the time, and the work that they were doing to try and get evidence to the patient's bedside, I should say, and to develop the critical appraisal skills of medics to try and bridge this gap between what we know and what we do. And I was certainly caught up in this movement, but my understanding was messy and it was naive. And I'll give you an example. One of the obstetrics and gynecological consultants that I worked with, he was also an academic, so he had a clinical academic career. He was really concerned with the variation across the different firms, as they were called at the time, the different teams in the hospital around their approaches to assisted vaginal delivery. And so we set out to look for evidence, and we searched, and some of these things were really innovative at the time. You know, we searched on a dial-up modem, the Oxford database of perinatal trials. We searched for systematic reviews published through the effectiveness in care in pregnancy and childbirth, some of the work around Cochrane, really cutting edge times that we were doing this piece of work. It was back in kind of 1993. And we put together a briefing of evidence-based recommendations to set an audit standard. And we brought together colleagues that were all working in this area. So, you know, consultant obstetrics and gynecologists, along with their juniors at the time. And this colleague I was working with and I were completely convinced that, you know, we were presenting the evidence. The evidence was absolutely clear that it was better to use a ventouse cap rather than forceps as a means of supporting delivery. And we felt that this should just be adopted over the firm. We'd got data on the audit practice. We got data from a whole range of things. But that medical audit meeting was a really salutary experience. We'd envisaged this linear path between what the evidence said and the collective decision to move to ventouse as a standard procedure. There were no financial implications around this. The two alternatives were available. Everyone was trained to use both. There was nothing that really that would get in the way. But this did not happen. Our carefully constructed evidence was countered by a story, a senior consultant who eloquently steered the meeting to a different outcome. His story was emotional. It was delivered with great aplomb and authority. It was a real opinion leader. It contained the experiential knowledge of his use of the ventouse cap in clinical practice, and it outweighed our knowledge. Our knowledge was dry. It was a summary of average effects. It linked to a systematic review. It was all the things we should have been doing, but it absolutely did not hit the mark. And consequently, the meeting agreed to move on without setting the standard we'd hoped. And at the time, I didn't label this experience about the different types of knowledge. I wouldn't have thought about it as that, you know, the experiential knowledge and that he was an opinion leader or any of those sorts of things. These ideas came much later in my experience of trying to get evidence into practice. My feelings at the time were simply frustration that my objective evidence had been easily dismissed by a simply emotionally gripping story. And at the time, I didn't think about the power of stories and how useful they can be in mobilizing evidence. I'd not spent enough time thinking about knowledge, whose knowledge, the power of knowledge, or how it's mobilized. I didn't recognize the complexity of the relationship between evidence, policy and practice, and how it's nuanced, it's dynamic, it's political and it's contested. I thought it was this straightforward bridge between what we know and what we do, and we just walk across the bridge and effectively bridge the gap. So that was a salutary experience, and this was then really reflected in the work undertaken by John Gabby and Andre LeMay, where they really brought this complexity around evidence to life. So they basically hung about in general practice for quite a long time. And they came to understand that GPs, despite having access to distilled guidelines of best practice, you know, we've got the hierarchy of evidence on the screen, and they had access to filtered guidelines that brought together a variety of evidence that allowed them to make decisions. But they didn't just use the guidelines, they created a whole sort of set of, and the way that Gabby and LeMay describe it is they created their mind lines. They looked at evidence from numerous sources. They got local guidance, they got central guidance, they got the views of opinion leaders, going back to my obstetrics and gynecologists. They got details from journals, magazines, colleagues, conversations with colleagues, the patient's view, their experience. A whole range of things was happening during the consultation that meant that the guideline wasn't necessarily just directly implemented. And this is a really helpful study, I think. This sort of sense of it helps us explain the gap between what we know and what we do, and of course is even more complicated when we're working in a political environment such as local government, i.e. an overtly political environment. So this is a really useful book and it's helped shape some of my thinking, and this is much more around the move to evidence-informed policy, which we're all really interested in. It's open access, so it's really worth dipping into, and I find Catherine Oliver's chapter really helpful. She makes the argument that these rationalist models tend to dominate evidence-based policymaking, so they prioritise things like randomised controlled trials and systematic reviews. And a rationalist model is this idea that we can gather absolutely everything we know on a subject. I tried to do that around assisted delivery. Everything we know on a subject, we can synthesise it, we can package it, and action will follow. But this model really oversimplifies the reality. It ignores the values, it ignores politics, and it ignores complexity. It also means that we narrow the evidence base because we may think about only looking at particular types of evidence, and it becomes quite a technocratic process. And there's also the danger that policymakers may just cherry pick the evidence that suits decisions that they may have already made that fit in with their values or fit in with the politics of a particular situation. So Oliver argues for an alternative approach, a kind of a political economy of knowledge, where the focus is on understanding and acknowledging the power. That senior consultant had more power. He was very able to really influence the importance of broadening participation and being more inclusive about the type of evidence and how evidence is produced, who owns it, who asks the questions. And this alternative, which I really want to kind of advocate for in the rest of the talk, makes us consider who's producing the evidence, how is it valued, and how power might shape its use. And that allows us to move forward in a more inclusive, transparent system where we can value diverse approaches to create evidence, so diverse methodologies, and where we can foster more collaboration and co-production and have local people at the centre of some of this work. So I find Catherine Oliver's work really interesting and definitely worth dipping in if you're not familiar with her work. And I probably have not done justice to what she talks about there. I suppose the next thing for me that is really important, and any of you that are working in a public health team within local government or are working in this this route where you may be working between academia and local government, or you're working in a broader public health context, one of the most important things really is the context. It is really, really crucially important. In local government, we tend to talk much more about evidence-informed policy. And if you consider the items that are in silhouette, so again, this is one of my kind of metaphors to illustrate a point, all of these things in different contexts work as a chair. So if you think about that dental chair in the middle, that works as a chair in a dental surgery, but it doesn't work as a chair in the ladder or the beach. So let's do the beach scenario. It doesn't work in the beach scenario, and then it wouldn't be a very comfortable chair on a beach. So where you're doing the work and what's the sort of the construct around where you're doing the work is really important. And in local government, there is really something about how the place operates and what is important in there. So context is super important. So when we talk about evidence-informed policy, this is that decisions are guided by evidence, but they're balanced with the context, the values, and the practical realities of actually delivering something. If we think about, for example, something like NICE public health guidance in particular areas, if that was just delivered exactly as it was set out, that might blow the entire budget for a public health team. So there are really practical realities of being able to implement a particular policy, to being able to bridge the gap between evidence and practice. I guess the point I'm trying to make here is that local government operates in a complex environment which requires some flexibility about how we use knowledge. And Ray Pawson, back in 2003, looked at the different types of knowledge that we use from an adult social care point of view. Some of these mirror the work that Gabby and LeMay did, but this sort of sense that there are different types of knowledge and they're all valuable, and evidence derived from research is only one part of this picture. The other thing that's important to know about the types of knowledge that Pawson identified is that there's no hierarchy there, unlike the slide we had earlier where we've got the triangle of the sort of hierarchy of evidence with systematic reviews at the very top. Within a setting such as local government, the different types of knowledge are all valuable and they're all used at different times. So if you're trying to inform a decision, you've got to be really mindful that there will be other parts of knowledge in the process. That's why it's so difficult and so complicated. And hopefully towards the end, I will be able to give you some examples of how we've tried to address some of these issues within HDRC Doncaster. The next couple of slides, I'm going to draw on a couple of studies that I've been directly involved with. So this was a study that we did a few years ago when we were looking at how a health economics modelling tool, which was developed by academics at the University of Sheffield, with the view that you could plug in lots of information that you might have, and the evidence from that would support commissioning decisions. And the team were really interested to understand what people who were commissioning any work around diabetes services or any diabetes prevention work would think about this. And our findings were that there were two main themes, really, that there were very different evidence cultures, that within local government decisions were highly politicised, that councillors were members valued local acceptability and community insights, whereas public health managers tended to prioritise the scientific evidence. And so there's a real gap there, and that kind of can make things quite problematic at times. But evidence competes with other sources. So this is reflecting some of the work that Ray Pawson talked about, you know, that there may be NICE guidelines, there may be local data, there's experiential knowledge, there's cost, there's what the people might think. There was a whole range of things, but this sense that evidence was competing with other sources. The commissioners that we talked to distinguish between clean and dirty decision making. This sort of sense is that they describe the research as clean, objective, those sorts of words that you might describe around research, even though the reality of doing research may not reflect that, versus the sort of the dirty world of real world decision making, which was messy and pragmatic, and it was influenced by politics with both a big and a small p. We also found that evidence was often used to justify pre-existing decisions rather than drive them. And the commissioning in this area was not straightforward. It wasn't, you know, we'll do this, well, one person commissioning this service. The decisions were spanned across multiple services, and prevention and management of diabetes are interlinked and entwined. It's a whole sort of system around it. We found that the tool needed to fit in with existing processes, and those of you working in local government note that there are specific decision-making cycles requiring papers at particular times, and the tools needed to kind of fit into that process, couldn't take too long, needed to be done in a similar way perhaps to the way that the policy might be being developed. And the adoption of this really depended on this being a corporate priority, and so there was something important about that. But fundamentally, we found that pragmatism really mattered. They needed to be easily understood and integrated. They didn't need to be interpreted by an academic, for example. So ultimately, we found that evidence use was negotiated amongst competing priorities. We recognised that this tool had been created in isolation, and it would have been much better if it had been co-produced with the end users for local relevance. That the evidence needed to be framed as part of a broader decision-making toolkit, not a standalone solution, and that we really need to recognise the diverse evidence cultures and the political dynamics in local government. We've tried within HDRC Doncaster to take some of this thinking and some of this learning. Oops, I moved on a slide too soon. Apologies about that. As I said at the beginning, I've been obsessed with this gap between what we know and what we do. And in 2014, I was fortunate to receive NIHR funding to do a PhD that focused on evidence and local government officers. One of the key findings was that public health in local government was a craft, and that the technical evidence-based knowledge that we held needed to be woven into policy and practice, and that there needed to be a sort of a resource exchange between newly arrived public health officers in local government officers, and politicians exchanging what we knew and what they knew. And it really relied on mutual respect, and that to do a really skilled job as a public health specialist in local government, there's this sense that you need to balance the different types of knowledge within the decision-making process. But we have an absolutely huge opportunity as a result of both the RSS Public Health Hub and the deployment of LARPs across many local authorities in the country. We have the opportunity around the 30 HDRCs. This investment in research and the wider determinants of health could really advance this idea of becoming more knowledge informed, knowledge rich in our decision making. And it can do it for a number of reasons. It can really help align the research that's undertaken with local priorities that are important to councils, things around housing, employment, education. It can help democratise knowledge production so that people working in this space are working with local people. It can build capacity about what knowledge is and how you might mobilise it. And it can actually, and this is a bit that really excites me, it can encourage pluralism of methods, that we can move away from particular ideas around the, randomized controlled trials being king, to much more participatory approaches. It can support mixed methods work. We can learn by doing in this area. And there's an opportunity to almost leverage councils as policy labs, generating local relevant evidence that can also be useful nationally. So there's a fabulous opportunity there. And what I'm going to talk to you about in the next few slides is how we've tried to harness this opportunity. So I'm going to tell a series of impact stories, but they're not meant to be given as we've done this and it's all been great. I want to talk about them in terms of we've done these pieces of work, because we've had the resources and the time to build trust, we've knowledge, we've been able to have some impact. So the message here really is about the need to build trust and to work in a mutually respectful way. So our first story then is around trying to use evidence to inform the work of the Doncaster Fairness and Wellbeing Commission. It was set up to answer a really pressing question: what does fairness look like in Doncaster? And we were really fortunate that this was being set up. So luck can sometimes play a part in this. We were being set up as an HDRC at the same time as the Fairness and Wellbeing Commission was being established. And we knew that the Fairness and Wellbeing Commission and the Secretariat who were going to run this alongside the commissioners would want to feed evidence into the conversations. And so we were able to effectively have two of our embedded researchers, Professors Andrew Booth and Professor Liddy Goyder, both from University of Sheffield, to work alongside the commission for the entire length of time that the commission ran. So there's a timing issue here. And them getting alongside meant that instead of them going away and reviewing the evidence and presenting it in a sort of quite transactional way, they were able to really listen to the debates, the conversations that commissioners were having, the other bits of evidence that the council were putting together, some of the quantitative evidence, and they could help change the way that they presented their evidence. They use some quite innovative methodological ideas. They use lots of logic maps, and they stood in meetings alongside people explaining, making sure that people really understood. They also use bits of ethnographic research to capture lived experience of the realities of life, because it's one thing here in the start that 21,000 children grow up in poverty at the time in Doncaster, and 27,000 working adults earn less than the real living wage. But actually, sorry, I don't know why my slide automatically moved on then. But actually, when you can see some ethnographic research that they turned into personas that brought stories to life, it really helped the commissioners understand their reality and to begin to think about fairness. And so what we've got in this is as a result was a summary of recommendations. They were also able to explore best practice examples from elsewhere, to have almost a smorgasbord, was the way that Andrew Booth talked about it, of different approaches, things that had worked elsewhere, to spend some time thinking about whether these things might work in Doncaster. And then the really useful thing is that Andrew and Liddy haven't gone anywhere. The policy officers haven't gone anywhere. The HDRC team hasn't got anywhere. And so we continue to work to embed and ensure that some of these recommendations are taken forward in other policy areas, that we're reaching back to what were recommendations of the fairness. How can we weave that into policy and practice? And that for me feels really impactful. But this took time. This took people being prepared to work in slightly different ways. This was very different to what we might have done as a council, which may have been commissioning an external body to review the evidence and give us a report. This was that report being slowly developed in a co-produced way and explained and made to be understood as we went along. And that feels like the difference, that we had the opportunity to really understand the messiness of this world and to work out how best to drip and to craft storytelling as part of this this project. So the next example that I want to talk about is some work that we did from the point of view of developing Doncaster's women's health strategy. So we knew we didn't need to act particularly fast in this area, though it's a really important issue. We wanted to really build an evidence-informed strategy. And what we did with this is we started off with a kind of a needs assessment in this area, but we did that in a very co-produced way with our academic team, with members of the core HDRC team, with public health practitioners. And that gave us some insights as to where we may need to go. And this became a real springboard for action. So as a result of the findings of the initial needs assessment, we were able to convene a big stakeholder event that had health, local authority, voluntary sector organisations, and this sparked new collaborations. It sparked funding bids. Actually, we applied for an NIHR application on menstrual health as a result of this work. It influenced discussions at the Health and Wellbeing Board. We were able to align local priorities and national strategies. So we were mobilising what we'd found out from this point of view, and the momentum from this continues. So we've just had a second big workshop around this particular area. We're about to go out for commissioning for our sexual health services in Doncaster. The women's health strategy provides the evidence base and the groundwork to do that. So that's an example of something getting into practice. We also recognised that we needed to think about the commissioning and our local contraceptive services. So as part of this, we've done some survey work to really understand aspirations of local people around contraception that we will use directly in policy. So there's lots of opportunities here where we've used data as a starting point, and then we've then taken it in a much broader sense to have some really pragmatic conversations. But you'll also see on the slides that we've got a visual summary. We've also developed this lovely graphic that around Doncaster's women's health that's kind of everywhere, and it feels like a bit of a call to arms. So we found that these are just different ways of ensuring that people can see what the evidence base is, but the weaving, the crafting of how we tell the story really happened in those stakeholder events, and we will continue to work on this area. So again, it's that sort of timeline. There's no sort of magic bullet that you're going to find the perfect trial that's got all the answers, or the perfect bit of evidence that's got all of the answers. This is an ongoing and much broader conversation. And then the next sort of example that we've got that is not completely finished yet, but we had a scenario where we were facing a gambling license application, and a recognition that this wasn't just regulatory as an issue, but that the public health advice on that needed to be around safeguarding communities that are already vulnerable to harm. But simply saying that isn't sufficient. So we did some work where we were able to convene people really quite quickly, and we called it the Gambling Harms Project, to try and provide a timely solution that could be fed into the licensing decision-making process to the right committee. So colleagues sitting in the university, but also colleagues in the public health team, work together to produce an evidence briefing, because that was the right model to fit the licensing. That's all about papers that are going. So an evidence briefing that explained all of that, but also a risk map that combined both global research, national policy insights, and local data on gambling premises, but also population risk factors. And this was really useful. We were able to use this to actually object to a license application, and this demonstrates how evidence can be used when it's ready at the right moment. And I suppose that's the other thing that's important in all of this, and it's really difficult to get right. There's definitely a timing thing, both in the sense of working alongside people over the period of time, but there's a timing thing in terms of pace. And we were fortunate that we were able to do this at the speed the policy needed. But that also means that you can provide evidence in a methodical way at the speed of the evidence, but you also can't allow the perfect to get in the way of pulling something together that's useful and crafting something that was really useful for the policy officers who will be presenting this evidence at various committees. And this feels like a really replicable model. It used visual tools to be able to map licensing premises. That meant that we could make complex evidence more accessible for non-specialists, and that is sometimes some of the problem that we have as public health specialists, where we may have some really complex technical knowledge. How do we go about communicating it? So there's something about using mapping, using different ways of crafting that evidence into conversations to enable people to see the bigger picture. Because the smaller picture may well be that you want to give a license in a particular thing because of the economic benefits of perhaps doing something, but presenting evidence in a more visual way and allows you to have the bigger picture around some of the risks around doing that. And that brings me to this idea of trade-offs. Any of the decisions that you're making are definitely going to have some trade-offs. It's messy, it's complex, it's contested, and it is politicised. But some of these tools and some of this learning is really helpful in all of this. None of this negates from the fact that this is a hard process. But I think the thing that cheers me in all of this is that there's lots of knowledge out there around how to do some of these things or what things you might try. The NIHR has, for example, funded something called Know Public Health, which is about how different techniques for mobilising evidence in local government. When I stop sharing my slides, I'll put their website in the chat because it's a really useful resource. One of the other opportunities that we also have is that Andrew Booth, who's one of our embedded researchers, has recently set up a kind of community of practice called Headspace. I'll put the contact details and the information that they're doing, that's all about bringing together people who are interested about how we can access, synthesize, critically appraise and get evidence around the health determinants into practice in this quite complex environment. And so that, you know, that may be a community of practice or a community of interest that people will find really, really helpful. So I will move on to what is my very final slide. Really, I'm conscious that I'm probably finished a few minutes earlier than I intended, but I wanted to sort of thank you for listening. I hope that's been really helpful. I can't see anybody at the moment, so I don't know whether there's a smiling, nodding, or have disappeared. But I think that's been a bit of a rapid look through both the history of evidence policy making and a sort of almost a call to arms that we need to think differently about how we do some of these things. We need to recognise the messiness, and we need to recognise that within that messiness there are people with different elements of power and ability to be able to do things, and how can we democratise that a little bit more. And then I suppose the really positive thing is that the NIHR's investment in this means that we really can think and we can learn by doing, and really what we need to do is reflect on our learnings, write some of that up, share it, get involved in things like Headspace and Know Public Health, so that we build a community of people working in this area who can recognise the need to craft and to weave evidence into the process. I hope that's been useful, and really happy to take any questions. And I'll stop sharing.
Thank you, Susan. That was a really comprehensive take through the information in 40 minutes. You did so well to cram so much into that. Goodness. See, there's some questions coming in. I'm hoping you can see hands coming up now. So I think Ed has the first question.
Thanks so much. Thanks, Susan. That's absolutely fantastic. Really brilliant.
Oh, thank you. That's very kind.
Looking forward for to the presentation and the notes, but I've scribbled some stuff down as I was listening, and so that's brilliant. I just wondered, and what you said about stories is such an important point, and potentially the smaller scale evidence, if you like, the sort of case study or the individual. Just wondered if you've got any sort of thoughts on the sort of scalability of things, because sometimes what can get dismissed as a bit of sort of anecdotal information rather than more sort of systematic research or larger scale research. And have you got any thoughts on ways that we can sort of maybe accentuate the benefits of smaller scale to reduce the risk of it being sort of dismissed as too anecdotal, if you see what I mean?
Yeah, I mean, that's a really interesting question. I suppose there's an opportunity to think about within any case study, a sort of and it's a perfectly legitimate method, case study research, isn't it, or using case studies in particular areas, is to sort of think about whether there's a bit of a mixed methods approach in there, as well as the summary of the case, if you see what I mean, to sort of go that extra step in looking at what else the literature might say in a particular area, or what other data we might have around something. I suppose my sense of stories is that they can be a really good way of mobilizing summaries of what we already know, if that makes sense. But I do think that if we can make, it's almost a contradiction in some respects, but if we can make case studies robust and work out how we mobilize them, case studies and stories are used all the time. You know, that story of the obstetrics consultant telling his emotional story is the thing that made the difference. So if we can mobilize a case study that is reflective of the evidence, and we do that in a storytelling way, that's still better than an opinion, if that makes sense. But it's a minefield, and that's why it's so complex.
Yeah, thanks a lot.
My next, Susan.
Yes.
I'm just looking for hands, but hi, Sarah. Good to see you.
And you, thank you very, very much. That was really brilliant and really insightful. And I've also scribbled down lots of notes, but I'm looking forward to sharing it with colleagues. I just wondered, when you've achieved so much and are able to communicate what you've learned so well, what you kind of see as what you want to focus on in the next sort of 15, 20 years, or whether there are things that you still really want to achieve, and what you see the risks in not, as all the threats to not being able to achieve that, particularly with the threat of the sort of Farage type government looming and their lack of respect for so-called evidence.
So the glib answer is retirement in the next 50 years. But I suppose one of the things that we've been talking about a lot locally is this sense of almost moving on from the idea of an evidence-informed stuff to a culture that is enriched with evidence, so that and that there will be a plurality around that evidence coming from different sources, different ways of knowing, led by potentially research that's much more participative, those sorts of things. And I'd really like to explore how we can make that available almost I mean, AI might be part of this. That could be a really positive thing, but it could also be a threat. But how we can develop systems so that decision makers have evidence at their fingertips evidence in a way that they don't at the moment. We collect lots of data, routine data in local government. We do lots of consultation. We tend to go back and repeat consultation rather than maximising what we've got. So thinking about a system, I often think about it in terms of the Tom Cruise film Minority Report, you know, when he was kind of stood being able to drive. So I kind of think about trying to create a culture where there is lots of evidence around, but also that is much more democratic in terms of who's developing the research questions and so on. I think that I take the point around the threat in terms of a changing culture around respect for evidence, but there's also something about reframing, you know, using the tools to reframe, to tell stories, to help to see the bigger picture. And something like the alcohol licensing, for example, is a really, really key example. Lots of evidence base might suggest that you wouldn't want to license more premises, but you might have people thinking about economic growth and footfall in an area and all of those sorts of things. If you can combine evidence in such a way that you've got something like our risk map from a gambling point of view, you can help show the bigger picture and recognise some of those sorts of trade-offs. And I suppose at the end of the day, in local government, we can only advise, politicians do decide. I can't. Oh, Kate, I think's next.
Yeah, hi. Yeah, okay, Bailey. I'm consulting in West Sussex County Council, and I'm really thanks. Incredible presentation, which really rings true throughout. I'm one of the people who moved from NHS into local authority, and that experience that you described, very, very accurate. I suppose so. As a county, very much engaged in applying evidence and then generating evidence now. You know, we're really interested in that and evaluation of all of our activities as part of that. I suppose in that and what you've said, you know, something for me about how do we, if we include, you know, all the types of evidence in this, you know, including people's voices and views and opinions, like the clinician that you were talking about with the very strong story. You know, there's just a question for me about how you balance that, and, you know, best ways of doing that. But I'm also really interested in other county, you know, big counties that have tried to do what we're doing, if you're aware of any.
Yeah, really, it's the $60 billion question, isn't it? And I think that's one of the things that came out of my PhD findings, the skill of balancing different types of evidence in a timely fashion, which is really difficult. And I think, you know, from a public health perspective, there's probably something that we need to do in public health competencies in training to really develop these sorts of skills of crafting things together. But I suppose there's always something about going to the question that you're trying to address itself in terms of what is the most useful evidence in this space, and then thinking about, if we've got a plurality of evidence in that space, how we can then mobilise it and craft it into an argument. And I'm not suggesting that anybody for 1 minute is just kind of finding a randomised control trial and saying, Mayor, let's do this kind of thing. But I suppose it's the thought and the critical thinking and being really thoughtful about how we can actually have those conversations. And they can take the form of formal briefing type conversations. There can be things that we put into corporate reports. There can be conversations in the corridor. There can be elevator pitch. You know, there can be a whole range of things, or there can be very visual. You know, some of the methods that we've tried are very kind of visual methods, and I think that that's a useful way of being able to spot. Linking things to local, as you know, is always really helpful. So, you know, using analogies and stories where you can bring in a person on the high street or a person who lives in X court or those sorts of things. Personas have been helpful for us as well. In terms of your second question, I suspect people in the Headspace community, that I think there's a couple of things in the chat about that at the moment, that I think that might be the space to find others who are trying to do things at a vast geographic level.
No, thank you. Really helpful. And I suppose I was very struck by you know, that non-linear thing, and feel a bit like some of the sort of best practice guidance isn't being referred to as much as it was. You know, so NICE is, for as an example, there are others, you know, really not appearing in the ways that maybe you'd expect anymore, and not being the automatic reference point. But that very powerful comment you made about evaluation around using it to justify what you've already decided, I thought was great. So thank you.
No problem at all. Ruth?
Yes, thank you. That was absolutely fascinating. And I work in women's health, public health, so your examples were extremely pertinent. I was just wondering your opinion on those emotional stories from loud, trusted voices. You did have a better term for it that I can't remember. Whether you feel that they play a role sometimes in exacerbating health inequalities, because if people are ignoring evidence and listening to those voices and putting them higher in that hierarchy, do you think that that kind of prevents critical thinking, and as I say, that disadvantages people further? I'm thinking, you know, maternal health disparities, or, you know, looking at the evidence starkly and nothing's changing. Do you think that plays a role?
No, absolutely. No, I agree with you. I think that we probably need to use the power of that, but we also need to be very mindful of charismatic opinion leaders, and so I suppose that I guess I'm advocating for critically thinking about the evidence, and then critically thinking about how we might mobilize that in different ways, which is different from a person telling a very charismatic story, or that can sometimes be an N of one. The example I gave, there was lots of, you know, very, very senior consultant, very respected senior consultant. But I can see him now. It was back in the day. He was tapping his pipe to make an emphasis, so you can tell how long ago it was that people were smoking in the workplace. And was able to really, really sort of tell a story that had such an impact. And yes, there's a danger that can exacerbate inequality. So I suppose it's about using some of these methods for good, if that makes sense.
Yeah. Thank you.
It's not, I mean, it's why it's so difficult, and it's why it's important to really think critically about all of these things. I think there's probably time for one more question. Andy.
Oh, thank you, Susan. I really enjoyed listening to that talk that you gave on evidence-based decision making. I just want to ask you a question on especially the power of stories and what they play in communities, because I work a lot in communities.
Yeah.
And I think there's a lot of literature around it in terms of evidence-based. There's Clifford Shaw, who's obviously cited in Gulbrium and Holstein's work. He talks about stories. That he believed that stories are conveyed by whose experience were under consideration, and they're more truthful and useful than stories drawn from other sources. So I think he was talking about them personal stories that when you go out into communities, you're listening to people's emotions, people's thoughts, people's feelings in terms of what things might impact on them in communities. And my question from it really is, are there any gaps in hearing the voices of unheard groups in our communities, and how do they play a part in being more inclusive and having them involved in that decision making process, especially around evidence-based work?
Brilliant question, Andy, and you make a really important point there. And I guess that's some of what Catherine Oliver is really arguing about, that we need to further democratise the whole evidence informed or evidence policy world to ensure that we have plurality of evidence, which includes voices of local people. And you could do that in numerous ways, can't you? I mean, you've obviously described some of those and some of the thinking in your question, but there's also something about ensuring that if we have the opportunity to think about how we might go about researching a particular wider determinants type issue in local government, ensuring that we work with people who are impacted by that particular issue or that particular inequality to understand it from their point of view, so we steer and develop the question, so we get the right research question, and that we also get the right research method, which might be much more participative, which might involve local people as researchers, you know, a whole sort of raft of different things there. And then I suppose in terms of people's voices in mobilising, I think it's important to combine some of those voices, things like the persona approaches that we've used, so that it's not a kind of N of one around an opinion leader, but it's not also an N of one around a person's experience, that we can kind of pull that together in such a way that we can use that to support all the other bits of evidence. I guess it's about getting parity, isn't it, between evidence from different sources, and that there isn't a hierarchy about some of the evidence being better than the other, but that is definitely the puzzle, I think. You know, so we're probably ending on a note of it's really hard.
Thank you, Susan.
Susan, we do have one question in the chat. I wonder if there's time to address it, from Greg. How do you translate the evidence base in a way that the community can clearly understand, so that they can understand the reasons why the decision has been taken?
That's an absolutely brilliant question. I think we're still learning how to do some of those things. I mean, I do think there's opportunities around using both infographics to explain things in particular ways that can often be simpler. There's definitely something around stories back to the community around decisions. I suppose some of those mechanisms that we've used, like you said we did type things, that can help explain things. But I think you've also got to ensure that, you know, particularly with any research that we're involved with, that sort of sense that we will go back to participants and talk about what we found, and ensure that they're not left out of the loop. But that's definitely, I mean, maybe that would have been a good thing in answer to Sarah's questions, think about how we better communicate decision making to our communities, to our residents, and take account of the variety of experience and the diversity of our communities.
Thank you. Well, the time's just gone 11 o'clock, so it's just left for me to thank you so much, Susan, for your presentation today and for addressing all of those questions. And thank you, everybody, for tuning in. It's been a really rich discussion, and hopefully we'll all see you again soon at the next webinar.